yeah?
Yeah.
Okay, right. So I'm Sheila. I'm an ST6 in rheumatology, and I'm going to talk to you about the acute hot joint today. Apologies if it's not a very exciting topic, but I was asked to whip this up at the very last minute, so I'll try my best to make it interesting for your level of training. So the objectives of the talk today will be to learn about the acute hot joint and the presentations, differential diagnosis, and how to manage an acutely hot swollen joint. I presume most of you now at F2 level kind of know what to do, but I think it's always important to just go over things from a rheumatology perspective, just so there are certain things that don't get missed in patients who present with this to the accident and emergency department. So I'll just start off by showing you different patterns of joint involvement. So those are just like skeletal drawings of different types of involvement that you can get with the different joints. And I'm just going to bring up a slideshow on my next slide where you can select what patterns you think accurately describe these four images. So a few seconds to take the images in, and then I'll just move on to the next slide where you can select what you think is the best description. So just go to the QR code, open Slido, and then select which options you think best represent the descriptions from the joint patterns above. If you want me to show the previous slide again, I'm happy to do it. Just let me know.
Can you show it again, please?
So you've all got the QR code. I can move back to the previous slide. Okay. We'll spend 1 minute on this, and then I'll move over to the next slide and see what you've selected for the polls. Right, so I'm just going to check the results now. I'll move back up to the slide in case anybody wants to see it again. Have you been able to select an answer on the poll?
It was only letting us do it if we could see this
See the
slide.
slide, yeah,
It wasn't
okay.
letting us do
I'll
it at
leave
the
it
same
there.
time.
I'll leave it there for a few more minutes. So we've got about 22 votes. Joseph, how many people do we have on the teaching today?
So we have 50 minus 3 of us, so 47.
Okay, so when we get to about 40, then I can then have a look and see what the results are.
Good.
Right, so we've got 35 responses. So I will try and see what the results are. So most of you said symmetrical polyarthritis, asymmetrical poly, axial, oligo. Yeah, so that's perfect. So that is exactly what the previous images show. I'll just go back to the previous slide just to describe that a little bit more. So this is clearly symmetrical polyarthritis. You can see the symmetry. You've got both large and small joint involvement, and you've got sparing of the distal interphalangeal joints. So this is a typical pattern that you get in patients with rheumatoid arthritis. This is an asymmetrical polyarthritis. If you say, for example, took out all the small joints and ended up with just the four larger joints, the elbow, wrist, knee, and ankle, you would call that an oligoarthritis. But you do have some SIJ involvement as well on the left-hand side. That is axial spondyloarthritis that you get with a bit of oligoarthritis as well. You can see this in patients with psoriatic arthritis, angst-spond, inflammatory bowel disease. And then the last one is typically something that you tend to get with patients who have osteoarthritis. So you have predominantly involvement of the distal interphalangeal joints. You have involvement of the fast metacarpophalangeal joint, as you can see at the base of the thumbs there. But you can also get this similar pattern in patients with psoriatic arthritis. So the presentation of the joints involved can tell you a lot about the clinical syndrome that the patient is presenting with. Right, so just to summarize what I've said about rheumatoid being symmetrical, osteoarthritis having more of distal interphalangeal joint involvement. So if you have a patient who comes with an acute monoarthritis, the first things you'll think of typically are septic arthritis. You think of crystal arthritis, so gout and pseudogout, then other inflammatory conditions like reactive arthritis or psoriatic arthritis. So even rheumatoid arthritis can just present with one joint inflamed. And then you can also have things like trauma from hematorosis. So we'll talk a bit about septic arthritis, which is classed as a medical emergency and actually does have a high mortality rate of about 10% if not well managed. So the spread can either be through the blood or through direct inoculation into the affected joint. So the risk factors, I think you all know this, is patients who are immunosuppressed. So lots of patients in rheumatology tend to take lots of disease-modifying medications and biologic agents, which significantly suppress the immune system. Patients who are alcoholic inherently have a low immunity and they're more prone to getting this sort of arthritis. You also have diabetic, steroid use, IV drug use, pre-existing arthritis in the joint. So the theory goes that if you have a damaged joint, say from osteoarthritis, then that makes, because it's altered the structure of the joint, it's more likely for that joint to be attacked by pathogens. So any pre-existing problems in the joint from, say, rheumatoid or osteoarthritis can make that joint more susceptible to getting a septic arthritis. Very low incidence of arthritis introduced by intra-articular steroid injections, but we do occasionally see patients who've come in for steroid injection, then come back later with an infected joint if the procedure was not done in an aseptic technique. Prosthetic joints as well, because they're basically foreign to the body. There is an increased risk of infection with those joints, and then patients finally with indwelling catheters because of bacterial seeding through hematogenous spread. So the common organisms, I think you've probably all seen blood culture results from septic arthritis. So you've got Staph aureus, MRSA, and then these other few organisms further down there. But Staph aureus, far and large, tends to be the most common organism that's cultured from the fluid. So the clinical features, so one thing to understand is that with septic arthritis, the presentation is what we call subacute. It doesn't come on, say, within 24, 48 hours. It tends to have this sort of grumbling onset. So usually patients can be symptomatic for about 7 days, sometimes even up to 2 weeks before they present with a painful, hot, swollen joint. And it commonly affects the knee joint. You do have fever in about 50% of patients, but be aware because about 50% of patients do not present with fevers, especially those patients who are on immunosuppressive treatment. They don't mount a typical inflammatory response, and therefore they will not have the typical presentation that a normal, healthy patient might have. So in terms of diagnosis, we know the gold standard is obviously culture. So you send that for gram staining. So a gram stain can be done very quickly in the lab. You can get the results within about an hour. So if you're worried about whether this could be septic and you really want a quick turnaround result, just send it to the lab, ask for a gram stain, and then you can start the antibiotics straight away. You also want to check for crystals because you can have coexisting inflammatory arthritis with gout and septic arthritis. So I always make it a habit just to ask for crystals, just to make sure that we're treating everything at the same time. And if it's a prosthetic joint, do not attempt to aspirate that joint on your own. Obviously, call orthopedics. You also need to send blood cultures for these patients. We said that about 50% of these patients will have bacteremia in the cultures. You can do x-rays of the joints, but this may not be very useful in early disease because the pathological process takes a while before you get damage to the joints and you start seeing the changes from the infection within the joint. So x-rays can help, but not entirely useful in the early stages. So in terms of management, obviously you give antibiotics IV as per your local guidelines based on sensitivities, analgesia, joint washouts, and then surgery to remove implants if it's a prosthetic joint, but that's an orthopedics decision. So I'll give you a case presentation of a 65-year-old lady who came into A&E. She was off legs, came in difficulty mobilizing, had a swollen left knee. She lives on her own. She's independent with ADLs. She has a history of rheumatoid arthritis, high blood pressure, and fibromyalgia, and her medications are amlodipine and amitriptyline. So that's the summary. So you've got the baseline background history, functional status, past medical history, and her relevant medications. So on observation, her temperature was 36.8. She had an effusion on her left knee, which was tender and warm to touch. She had no synovitis in the rest of her joints, and she'd been obviously struggling to mobilize, therefore had been referred to orthopedics. Investigations-wise, she had a raised white cell count of 14.2, neutrophils of 90%, and CRP was raised at 32 with an ESR of 48. So, is there any further information you would like to know at this point about this lady before deciding on how to treat her? So go back to Slido and just type in your comments. I've never tried the comment Slido thing before, so we'll just see how well that works. If not, you might just have to shout your answers and then we move on in the interest of time. Okay, there's a brilliant questions. Any falls or recent trauma? No. No falls, no recent trauma to the joint. Any fever? No, she's not been febrile in ED. We've checked her temperature. That was fine. Any recent surgery? No, she hasn't had any recent surgery. Any prosthetic joints? No. Is she systemically well? She's otherwise well, but feels a bit rough because obviously she can't mobilize. But there's nothing in her observations that tells you that she's, like septic or anything. Weight-bearing status, she's off legs because of the pain. Does movement make it better? No, she's off legs because it's painful. Any allergies, any intra-articular treatment for her RA? No previous intra-articular injections. No previous damage to the joint, apart from having rheumatoid arthritis, which may have left some residual joint damage. Has she ever had this before? It's not presented like her typical rheumatoid arthritis flares, that much I can say. Has she tried any remedies at home? She's tried pain relief, that's not worked. Yes, perfect. Immunosuppressive treatment. So that is the golden question in this lady. So moving on. You've all asked the right questions, but the key question is, if you looked at her medication chart, there was no mention of disease-modifying treatment or biologic treatment. So what is she having for her rheumatoid arthritis? Because that could be really important in defining, in establishing how she will present with an acute infection. So she was on Humira, which is a biologic treatment, so adalimumab, which she injects every fortnight, and she also takes methotrexate 15 milligrams weekly. Now, the reason why these medications are not on her medication record from the Greater Manchester the GP records, is because the Humira is prescribed by a rheumatologist, so it's a specialist-only prescription drug. She's also having methotrexate prescribed by the hospital, which is on her clinic letters, so not necessarily made it onto her routine kind of medication chart. So that was a really important question that was missed when she was seen in the ED. So orthopedics was called in. They saw her. Obviously, they felt that this was not a flare of rheumatoid of septic arthritis. It was a flare of her rheumatoid arthritis because she was virtually asymptomatic with only mild inflammatory markers, which you can get with rheumatoid arthritis flares. So they sent her home. Now, at this point, what would you do in terms of, had you been the doctor seeing her with all the information that we know now, what would you have done differently? So just let's go through this quickly and then we can move on to the rest of the talk. Okay, perfect. So I think all of you are leaning towards the right thing. Aspirate, send for culture, and start antibiotics. So unfortunately, this lady was sent home, but knowing that she's got an autoimmune disease, our patients are usually very keyed in. She rang us the following day and we brought her in because she was still in pain and she was worried about this joint. And it didn't feel like her usual rheumatoid arthritis flare. So before you label a patient as having an RA flare, ask if it's similar to their previous presentations. They will give you that answer if it's not. So we brought her in, aspirated her joint, pulled out some very thick green synovial fluid, which is obviously infected. We didn't culture anything. I'm not sure why on this occasion, but we treated her for septic arthritis. She got better and she went back home and recovered very well on oral antibiotics. So the learning points for this particular case is always ask about immunosuppressive treatments. It's not every patient with an autoimmune disease or immunosuppressive state that will present in a typical manner that you expect, so textbook presentation in medicine. So always just keep your options, have a wide sort of, just be open, essentially. Her inflammatory markers were mildly raised, but not very much so that you'd expect in a septic arthritis, but still she was unwell. And some patients who are on specific biologic drugs, so I know you've probably all come across tocilizumab, given it was used in COVID quite widely. So that medication can suppress your CRP, and you might never have a raised CRP, even with infection on that drug. So always just be very vigilant when you're seeing patients on immunosuppressive treatments. So I'll go through gout very quickly. And then after that, maybe we could if we have some time for case presentation, brilliant. If not, we'll just finish and wrap off. So risk factors, I don't need to tell you all of this, but there's CKD, there's excessive alcohol intake, large amounts of red meat, and then specific medications, diuretics that you're all aware of. And one of the key things that happens, like when we get called in for an inpatient referral for a patient with gout, it's almost always somebody who's had an acute insult. Say, for example, they've had surgery or they've had a myocardial infarction, then suddenly they've had a hot swollen joint. So obviously those are stressors that precipitate these flares. So the fast attack is always, well, usually the MTPJ in about 70% of patients, but it can affect all other joints. The inflammation comes on very quickly. So compare this with septic arthritis, which takes a few days, so grumbling before it flares up. With gout, usually within 12 to 24 hours, it's very quick onset. The symptoms come on very rapidly and go down just as quickly if you treat them adequately. And within days, patients usually improve even without treatment. And it's not clear how the body turns off a gout flare, but somehow it just does it. And there may sometimes be systemic upset in these patients. So we have different phases of the gout flare. So the initial flares usually involve a single joint. Most often you'll have the big toe or the knee that's affected as a first presentation. But over time, the flares begin to involve multiple joints in some patients, and they may be accompanied by systemic features like fever. So it can be a bit confusing for an infection, but then just remember that very subacute versus very rapidly acute onset, that can help you differentiate between the two. And people with osteoarthritis can experience gout in their fingers rather than the toes. So it's the concept that we spoke about before in terms of having pre-existing damage to the joint that then makes you more susceptible to getting infection within that joint. So you have this period called intercritical gout, which is the time between the gout flare, between two different gout flares. So the second flare usually occurs within a couple of years of the first flare, and additional flares may occur thereafter. So if you leave patients untreated for a period of time between if you leave them untreated, the time between the flares may shorten, and then the flares become increasingly severe and prolonged, and therefore involving multiple joints. So if you have a patient who's come in with a second acute flare of gout and is not on any treatment, we'd normally advocate to start them on allopurinol once that acute attack has settled. You've also got tophaceous gout, so that's the tophi you can see on the left-hand side. Pretty sure some of you have seen lots of patients with this presentation. So this happens if you have repeated flares of gout that leads to persistent hyperuricemia and deposition of the tophi within the soft tissue. So these are just urate crystals in the joint. And the tophi can be destructive and cause damage and deformity to the bone, and then you end up with this gout, chronic gout arthropathy, so chronic tophaceous gout. So other presentations of gout, you can have uric acid stone formation as well. So diagnosis, gold standard. So I don't want to get a call saying, oh, this patient's got a raised uric acid level and it's not a typical joint that's affected by gout. Say, for example, they've got a shoulder that's swollen with a raised uric acid level. Could they have gout? You cannot diagnose gout from pure blood tests. The gold standard is a joint fluid analysis. And we find that in about 50% of patients in an acute attack, the uric acid can be normal. So checking that uric acid, it might be helpful if it's raised, but if it's normal and I think it's gout, it doesn't really tell me anything. So the good thing is, the best thing to do is to stick a needle in the joint, send the fluid off for analysis and confirm that there are urate crystals in the joint. Other bloods looking for inflammatory conditions, infection are useful, as well as X-rays to look for things like chondrocalcinosis. Now, the aims of management, you all would know, is relief of pain and inflammation and preventing future attacks. So we tend to give NSAIDs in the acute presentation, if not contraindicated. We can also use colchicine for about 3 days. Now, one thing that I've found with rheumatology, so you might get a prescription of colchicine that's going on indefinitely for months. So we don't always give it for 3 days. If somebody has gout and we want the GP to start them on allopurinol when they leave hospital, we would normally prescribe colchicine for at least 6 months for them to carry on with. It basically helps prevent another flare of gout when they start the allopurinol. So if you do see that that's not unusual practice, that's what we do in rheumatology. We just give extended periods of colchicine as prophylaxis from a future gout attack. And then corticosteroids, so we could give oral steroids, intramuscular, intraarticular, whichever we think is best indicated in the patient, depending whether they've got like an infection or they're physically unwell in hospital. So we'll decide which is the best route to give the steroids from. But always remember, if somebody's given corticosteroids, especially orally, well, oral corticosteroids, we always make sure that they're prescribed PPI cover so we don't end up with a GI bleed. So you know how allopurinol works. And we start that once an acute attack resolves. If we find a patient who's already established an allopurinol when they come into hospital, do not stop the treatment. Carry on with that. We can give colchicine or steroids in addition to that, but don't stop the allopurinol. On the other hand, if you find somebody who's probably needing to start treatment for gout because they've had a second or a third flare, we wouldn't start allopurinol in the acute attack. We'd wait until that attack settles and then start the allopurinol a few weeks later. The reason behind this is because allopurinol, as I've said, it acts by inhibiting xanthine oxidase, and that lowers the uric acid levels. So a sharp drop in uric acid levels can trigger release of uric acid from the crystals that are already in the body, and then that makes the gout attack, the gout flare much worse. So always start allopurinol a few weeks later once the acute attack has resolved. And if you do get an attack on allopurinol, we advise patients, don't stop the treatment. The treatment is working. Just get in touch with your GP or rheumatology and we'll give you an additional medication to try and reduce that flare, which is why I explained earlier, we give colchicine alongside the allopurinol. So other medications you've probably come across is febuxostat and probenecid. We don't have time for this. I was going to try and see if anyone's a smarty pants and wants to try and tell me what this condition is. But if you have time, you can look it up later and then it's just one of those things you don't have to know, but it's nice to know. And then finally, we've got pseudo gout, which is CPPD. So you've probably come across this. If you look at the X-ray on the right, I'm hoping that every single one of you can identify what's wrong with that knee. So it's an age-related disease that's seen in patients after the age of 50. So if you have somebody who's in their 4th decade of life with pseudogout, think that there's probably a primary underlying metabolic disorder or a familial disease that's causing the crystals. Otherwise, it tends to happen above the age of 50. And you end up with this chondrocalcinosis, which is what you can see on the X-ray on that side. So the most common presentations are asymptomatic CPPD. They can come with, you can do an X-ray just incidentally and find that they've got chondrocalcinosis, but they're asymptomatic. That doesn't mean that you treat it. If it's not causing any problems, just leave it. If it's painful and swollen, then you treat it in that case. If they might come with an acute flare of pseudogout, who typically presents like a gout attack. Affects the knee, affects the hip. It can affect any large joint or even the small joints if they've got chondrocalcinosis in there. And you can also get presentations of pseudoarthritis and pseudorheumatoid arthritis, but I'm not going to go into that in the interest of time. It's just essentially they might mimic these existing conditions, but it is primarily gout, pseudogout that's causing the problems. So like I said before, if it's in a young person, younger than 60, ideally younger than 50, you need to work them up for hemochromatosis and other endocrine disorders that can cause chondrocalcinosis, so parathyroid disorders and low phosphate levels. So the clinical features of pseudogout, it comes in as acute monoarthritis very rapidly within 24 hours. And you get the typical symptoms of inflammatory arthritis, pain, swelling, warmth, and the knee is the most common site. You can get systemic upset as well. And any joint can be involved by CPPD, although the knees, the wrists, and the hips are the most often affected. Now, this is an X-ray of CPPD in the wrist. I'm hoping that you can all see that. So on the left-hand side, you can see there's some deposits there within the joint next to the triangular cartilage. And here as well, where the arrow is pointing, you can also see that there's a bit of calcification in that joint. So that's pseudogout. So if you have a patient, you've requested an X-ray, before you wait for an X-ray report from radiology, just try and look at it yourself and see if you can identify where the chondrocalcinosis is, because sometimes even a radiologist can miss that. So it's good to just train yourselves on how to look at these X-rays. It's very simple. This is what microscopy looks like for CPPD and gout crystals, so weakly positive crystals in CPPD and strongly negative crystals in gout, and the shape as well is very different. So investigations of gout, so if you have a younger patient, pseudogout, sorry, younger patient, exclude a metabolic disease, look for serum calcium, phosphate and magnesium levels, as well as ALP. Sometimes, not always, but sometimes if you think it's probably triggered by one of these electrolyte abnormalities, then it would be nice to look for that. Also, patients who have like thyroid issues can end up getting a lot of pseudogout. So if you think that there could be an underlying primary thyroid disorder, it's always good to send for those tests as well. In terms of management, again, like with gout, it's rapid relief of the joint pain and swelling. So you aspirate the joint, that is the treatment of choice, aspirate and inject. You can use NSAIDs, but obviously in elderly patients to try and avoid that. In that case, we'd give low-dose colchicine for a few days until the pseudogout attack settles. And if you can't give any other option, you can give an IM steroid or an oral steroid if the gout is in a very tricky place to inject and colchicine's not working. For at-home management, you can advise patients to use topical ice therapy. So in summary, is it sepsis? Is it crystals? So with sepsis, you look at the history of speed of onset. With sepsis, subacute 1 to 2 weeks. With crystals, usually very rapid within 24 hours. Gout, usually the first MTPJ, classical gout, don't need to do an aspirate in that case. It's obviously gout, treat it as that. In a patient who's, say, over 65 years, has osteoarthritis, subacute onset of joint swelling, and you see chondrocalcinosis on the X-ray, that's probably going to be pseudogout. When you send the aspirate off, though, they can sometimes find both gout and pseudogout crystals, in which case the management is pretty much the same, unless they're having repeated flares where you need to start them on urate-lowering therapy for gout. And then finally, you cannot always rely on fever, white cell count, and all these inflammatory markers to tell you if somebody's got an acute septic arthritis. And again, like I said before, uric acid can often be normal in acute gout, so that doesn't really hold much weight. Right, so when not to aspirate, obviously if it's a prosthetic joint, don't stick a needle in there. If they've got an overlying skin infection, you're going to introduce infection into the joint, so do not aspirate. Obviously, don't try to be heroic and aspirate difficult joints like the hip or the midfoot. Patients on anticoagulation, I would hesitate as an F2 to aspirate that unless I had some senior supervision, or you ask a rheumatologist or orthopedics to come and do it for you if you think it's gout or something. If it's infection, orthopedics. If it's gout, rheumatology are happy to do it. And then rapid onset of severe pain and tenderness at fast MTPJ. You don't need aspiration. That's usually typical gout. So these are the take-home messages. We've spoke about this before. And yeah, so hopefully you're more mindful when seeing patients with an acutely swollen joint from now going forth. Thank you. I'm happy to take any questions or send the presentation across if it'll be helpful for anyone.